Thank you for joining us and welcome to another edition of Health in the Heartland, a program dedicated to the health issues that affect you. I'm Karen Blakelock, and joining me this episode is Dr. Mohammed Iqbal, urologist. Thanks for being here, Dr. Iqbal.
I'm happy to be here.
Well, we're going to be discussing a common urological problem with males. Is that correct today?
Yes, ma'am.
And we'll be talking a little bit about something called BPH. Tell us what BPH is and what it stands for.
BPH is benign prostatic hyperplasia. It's basically enlarged prostate gland, which all of us men start getting when we are in like between 30 to 40 and then onward. It's a disease of the decades. In fourth decade, it's about 10%. Then every decade, it increases another 10%. And prostate gland is a small gland sitting just at the base of the urinary bladder. I can explain it to you. I have this model. Basically, if this is urinary bladder, we all know urinary bladder is connected to the kidneys. Both the kidneys, the drain is called urethral tube or ureter. They end up in the urinary bladder. That's where all our fluid, it accumulates, and then we have to discharge it. And for discharge, we need another tube called urethra. And right at the junction of the urinary bladder and urethra, you have prostate gland. The urethra in between the prostate gland is called prostatic urethra. Basically, it's a gland which, like a walnut or like a donut, and sits between the urethra and the bladder neck. And it starts increasing after we turn about 35, 40. And there are different reasons for enlargement. Is mainly because we are males, and also the testosterone in our body, it gives you increase in the size of the prostate gland with rapid proliferation of the glands and also the supporting tissue, which we call stroma.
So basically, BPH, which is the benign
Prostatic
hyperplasia, happens in males. Our prostate gland's there for a male.
Yeah,
it is there for a male. And then as they age, they become more at risk for this enlargement. Is that correct?
Yes.
Okay, now, some of the signs and symptoms. I heard you talk about urination. Is that one of the concerns that might trigger a man to think that they may start to have some difficulties with their prostate gland?
Basically, when the prostate gland start enlarging, they have difficulty with urination. They have frequency, getting up at night several times, feeling of not emptying the urinary bladder, going, then they have to go, sometimes they have to run to the bathroom, sometimes they cannot control, it's called urgency, and they can leak urine at the same time. When they urinate, the stream is small. Sometimes they have to just stand there and just relax, and then the urine starts coming out. Sometimes they have to keep squeezing and try to eliminate. So we have an AUA score with 7 symptoms, and they are not completely emptying the urinary bladder, daytime frequency, hesitancy when you go and try to urinate, loss of urinary projection, loss of urinary stream, getting up at nights, and dribbling and urgency.
So this could be actually disruptive to a person's lifestyle, correct?
It's a big quality issue for older men, and because they have to get up several times at nighttime, they have to go several times in the daytime. They really cannot go and attend any meetings. Most of the time, if they are driving from here to Louisville, they know they have to get out at least one time to urinate somewhere on 65. And wherever they go to the meeting, they need to look at different bathrooms before they can be comfortable. Because when you have to go, you have to go.
Right. And we want everybody to live very active and productive lives.
Exactly.
So, and we have this aging population anyway. We talk about all these different age brackets, and we know there's a majority of our whole national population aging. So we're seeing a lot of commercials on TV for all these products as we're aging. But how, if we're a male, how is it diagnosed that this may be a concern for them? Aside from the symptoms, they're going to come in. What does it take to be diagnosed and find out what we can do medically as far as treatment?
Basically, we do their history, then do a physical examination. In history, just like all those AUA score I discussed, there are 7 questions we always ask, and each symptom has 5 score. So the worst will be 35, and less than 7, that means the patient does not really have too much problem. Then we examine the patient's urethra, penis. We do a digital rectal examination. That's for 2 reasons, just to see exactly how big is the prostate gland, at the same time to feel that if there's any hard area which may suggest that there might be a malignant or cancer of the prostate, which is a completely different disease than benign prostatic hyperplasia. And after examination, we ask the patients to come back with full bladder, and we make them urinate on the machine, which assesses the flow of the patient. Normal flow is about 24 cc's Qmax, and most of these patients will have less than maybe 12 or 14 or 16. Then average flow is going to be not 18, which is sort of normal. It should be like maybe it might be 12, 10, 8, or 4. So we know the patient has a problem with urination.
Now I'm going to guess, and you're the expert in this area, but if I was a male and I was getting up in the middle of the night, I might think to myself that I'm not going to drink after a certain amount of time so that I don't have to get up. What are the suggestions there with drinking and the fluid intake too?
Yeah, you don't want to get dehydrated. So you have to make sure that you take fluids all the time, including in the evenings. And if there's a problem, then the first thing is you need to admit that there's a problem.
Right.
And most of men, including me, sometimes we just don't accept that we can have any problem with us. So, so patients really, some of them just keep on waiting, suffering, and finally they go into retention where they cannot urinate anymore. Right. Then it becomes an emergency. But if we see the patients early enough, then there are a lot of treatment we can do, which includes medical treatment, giving them medications. We can do, if medications don't work, then we can do a minimally invasive surgery. There are several of them. And then we can do a TUR prostate, which is an old procedure we used to call rotor-rooter job. But they used to have a lot of bleeding with that. And the exciting thing is we have a new treatment which is called green light laser. It's a laser-based evaporation of the prostate. We use KTP laser. It's 532 nanometer. And it has affinity to the blood vessels. And by affecting on the blood and blood vessels, it opens the prostate tissue, just like excavation, with no bleeding. And I have done a lot of these procedures now. It's very easy to do. Just have to get used to it and get better at it with experience. And basically what I do, I usually go in mark at the apex of the prostate, so I know where exactly I'm coming in all the way distally, because that's where the control mechanism is. And then I go ahead and open the lateral lobes of the prostate and the median lobe of the prostate. And finally, we're done. It's just like an open prostatic channel. And the patient should be able to urinate with no problem.
So is that, is there a specific age bracket and or patients that are better suited for that type of surgery than other patients? Just depends on their history?
Usually, we always start with medical treatment.
Mm-hmm.
So we give them the drugs we call alpha blockers.
Okay.
And there are several. One of them, initially we had sort of alpha blockers which were not selective. And the main problem, we used to get the low blood pressure with those drugs. Patients used to feel weak, asthenic. They usually had to have postural hypotension. They may even fall down on the floor in the morning. These were the initial drugs. Now we have a selective drug, which is tamsulosin, and that mainly affect on the neurotransmitters of the prostate and bladder neck. Then we have now super selective alpha blocker, which is Rabaflo, which only works for A1 alpha blockers because that's only in the prostate gland. So it's they're all very, very safe drugs. The only thing is they will, as a compound, will give you low blood pressure, give you a little bit of nasal congestion, and initially when you start, you might feel a little bit weak, but then usually get used to it.